There is no history of cough, breathlessness, hemoptysis. There is no history of edema of feet, no history of back pain or bony pain, no history of any lump or pain in the breast. In the past history, there is no history of diabetes mellitus or hypertension, no history of any medical or surgical illness in the past, and there is history of tubal ligation after her third delivery at age of 32 years. Family history, a patient mother, sister had similar complaint in the past and she expired at the age of 62 years, but diagnosis not known. Otherwise, family history is not significant. Coming to menstrual and obstetric history, she attained menarche at 15 years of age, married at 21 years of age, P3L3, normal vaginal deliveries, first childbirth at age of 22 years, lactation 1 year for each child. She attained menopause at 51 years of age. There is no history of OCP use or hormonal replacement therapy. No history of infertility. There is no history of missed abortions. Coming to personal history, there is no history of smoking or alcohol intake. She takes mixed diet and sleep pattern normal. To summarize, a 53-year-old P3L3 postmenopausal lady with history of tubal ligation presented with abdominal distension, abdominal pain since 2 months associated with loss of weight and loss of appetite.
Okay, Ravina. So you have presented a postmenopausal lady with abdominal distension, abdominal pain. So why did you specifically mention about history of tubal ligation there?
Sir, in tubal ligation itself, it is a protective factor. It prevents the coelomic spread of tubes. So that's why specifically I mentioned about tubal ligation. Sir.
But see, what is your differential diagnosis in this setting?
So considering her age, postmenopausal age with a short history of duration, I would like to consider it as malignant pathology. Could be arising from ovary. First, my provisional diagnosis. Second, any metastasis to ovary, GA malignancy, and colon malignancy is unlikely because there is no history of altered bowel habits and no history of melena. And any lymphoma can be present with abdominal distension and metastatic disease from the unknown primary. And abdominal TB, sir. Abdominal TB also can present.
Lakshmi? What is your priority among all these set diagnoses? How do you prioritize your provisional diagnosis?
Mainly, she's a postmenopausal female. And this abdominal distension, more specifically, she's mentioning about lower abdominal pain since 2 months and bloating sensation with early satiety also, ma'am, there is there. And she told about a complaint of loss of weight, but that is not significant here. Only 4 kgs in 2 months. Okay. So according to that, most likely this ovarian malignancies at postmenopausal age, which is more common because endometrium I ruled out because there is no history of any postmenopausal bleeding.
Now, okay. Is it possible that ovary can present with irregular bleeding? Is it possible that carcinoma ovary can present with irregular bleeding?
It is possible, ma'am, but in granulosa cell tumor,
chances are 0%.
That is only less than 5%. Granulosa cell tumors can present, but that presentation is of age is 30 to 40 years. My patient is 53 years. So okay. Median age of onset of ovarian malignancies will be 63 and 50 to 60.
Endometrial type of malignancy in the primary ovary can also present like bleeding period because 30% of them can have CDs. So I think we can finish with your presentation and then go on with the topic. Otherwise, your case won't progress. Okay, 5 more minutes. You can present your case and give an executive summary, and then we'll discuss. Go
on. Before going, Ravina, let me remind you. You have mentioned about history of tubal ligation in your summary. I think your first diagnosis is CA ovary. So I think adding those details in the summary is unnecessary because you mentioned about tubal ligation as a protective factor and your first diagnosis is probably ovarian malignancy, so it doesn't go hand in hand. So I think you should avoid that. Okay.
Okay, sir. Coming to general examination, patient, she is conscious, coherent, well-oriented with time, place, and person with ECOG performance status 1, with the BSA 1.42 meters square and BMI 20.3 kgs. Temperature afebrile, BP, pulse rate, respiratory rate, or with
Ravina. Just to interrupt you, Ravina, in between. You are now going to appear for the exam, or are you second year?
no, coming finally, ma'am.
Fine. So this she is moderately built and RA should all go for MBBS and MD level. At the DM level, you should start with the ECG performance status. No other what subjective terms. Just gone straight to ECG performance status. Okay, avoid that.
Okay.
Okay.
BP, pulse rate and respiratory are within normal limits. There is no pallor, icterus, cyanosis, clubbing, no generalized lymphadenopathy, no pedal edema, no inguinal nodes, and no supraclavicular nodes felt. Local examination, after obtaining consent and exposing the patient from nipples to midthigh, patient is examined in supine position. On inspection, abdomen appears uniformly distended with fullness in the flanks. Umbilicus central and everted, skin over the abdomen appears normal. Respective quadrants move equally and symmetrically with respiration. No localized asymmetry or swelling seen. No visible scars, sinus, dilated veins. No visible pulsations, visible peristalsis. No fullness in the renal angle. No cough impulse, perineal orifices. External genitalia appears normal. Palpation, no generalized tenderness, guarding or rigidity. No local rise of temperature. On deep palpation, no palpable mass appreciated. Liver and spleen not palpable. Abdominal girth of 105 centimeters at the level of umbilicus. No cough impulse at hernial sites. There is no spine tenderness. No supraclavicular node palpable. Coming to genital examination, examination of the external genitalia normal. Urethral orifice and vagina appears normal. On perspecculum examination, cervix appears healthy. No discharge from cervix. Pervaginal examination, uterus normal in size, bilateral hard mass of 4 into 5 centimeters felt in both lateral fornices, non-tender and bimanual palpation. Rectal examination, rectal mucosa free, rectovaginal septum free, no POD nodularity. Percussion, liver upper border of liver dullness, percussed at right fifth intercostal space along the midclavicular line, and lower border is not demarcated. The shifting dullness present, fluid thrill not appreciated. On auscultation, bowel sound sluggish, no brewy heart. Systemic examination, no nodes palpable in the linguinal region. Breast examination, no palpable lump or axillary lymph nodes. Thyroid examination normal. Examination of the chest normal and cardiovascular system normal. Examination of the CNS, higher mental functions normal. To summarize, a 53-year-old postmenopausal lady, P3L3, with history of tubal ligation, presented with complaint of distension and pain abdomen since 2 months, associated with loss of appetite and loss of weight. On examination, abdomen distended with fullness of flanks, abdominal girth of 105 centimeters at the level of the umbilicus, with shifting dullness present. Pervaginal examination, bilateral hard mass of 4 into 5 centimeter size, felt in both lateral fornices, non-tender and bimanual palpation.
Okay, Ravina.
So can you after the examination of the patient, streamline your diagnosis?
After
to 1 or 2?
After examining the patient, I would like to consider my differential diagnosis will be primary malignancy CA ovary, carcinoma ovary. Secondary, it should be Krukenberg tumor METS2 ovary, arising from unknown primary. GA malignancy is unlikely because patient told about non-specific symptoms.
Okay. Arun, do we have her actual reports or do we discuss arbitrarily? How was it? Ravina, do we have the reports of the patient?
Ma'am, I'm having the reports.
Okay.
Coming to investigations.
Just give the diagnosis, just give the investigations.
Investigations in my patient, CA, we have done first, outside they have done tumor markers, but we repeated the tumor markers again with CA 125 of 490 units per ml, CA of 0.71. MRI, which is done outside, MRA, gross ascites that extending to pelvis with thickened walls, irregularly enhancing peritoneal deposits, and heterogeneously enhancing omental thickening. There is peritoneal deposits and nomental thickening is seen, and there is irregularly heterogeneously mixed intensity lesions. Bilateral adnexal masses are there of 4.2 into 3.7 into 2.8 centimeters on right and left also with equal size.
Okay, just hold on. Hold on. So you find here is a bilateral ovarian lesions, which is going to you are going to deal with a bilateral adnexal lesion. What is a Krukenberg tumor? Define a
Krukenberg tumor is mainly solid
tumor.
Krukenberg.
Define a Krukenberg tumor.
Yes, Krukenberg tumor is a solid bilateral malignancy. Metastasis to ovary that arising from any unknown primary, like mainly first GI malignancy, followed by colorectal, breast, anything it can arise from.
Okay, basically it is a metastatic disease, but the name goes for the primary stomach. Yes. We have extrapolated it to other sites. Okay, so we'll stream down to carcinoma ovary. You feel it is epithelial carcinoma or an ovarian germ cell tumor in this age group?
Breaking, ma'am.
Is it epithelial ovarian carcinoma epithelial disease or other sorts of like sex cord stromal tumor? What do you think?
Ma'am, sex cord stromal tumors mainly young age they will present. My patient is elderly female, postmenopausal female. So first my probable thought will be carcinoma ovarium.
So what are the risk factors for C ovary in this patient and in general? What are the risk factors?
Yes, risk factors mainly early menarche and late menopause.
Okay.
Early menarche and late menopause, and smoking itself is a risk factor, but it is mainly in mucinous carcinoma it is more having this factor. Endometriosis is a risk factor.
Okay.
And history of
smoking is actually controversial. It goes in favor for one another protective. So that is controversial, but you can still mention it. Okay. Then what about OCP use?
OCP use itself is a protective factor, ma'am. Breastfeeding, lactation is a protective factor.
Okay. So in this patient, we would definitely do either a CT or an MRI, which the MRI finding you have suggested. In MRI, what all findings will you specifically look when you're dealing with such a patient?
First, in MRI, actually, we will do in our institution is CECT abdomen, ma'am, abdomen and pelvis. If there is there is no differentiation between benign and malignant, then we will go for MRI, abdomen and the pelvis. We have to see the mass, size and all, lymph node extension and all, and extent of the disease, whether it is spread to any other organs.
So, Ravina, for this patient, you have done MRI. So, is that the first investigation of choice? You have suspected adnexal lesion. What is the first investigation of choice?
First investigation of choice is ultrasound abdomen pelvis transvaginal.
Exactly. So you have what are the features which would suggest a possibility of a malignancy in an ultrasound abdomen?
Complex, yes, sir. Ultrasound abdomen complex cyst, sir. Irregular solid cystic lesion with the presence of ascites. Doppler also we have to see increased vessel tortuosity, density, and high systolic velocity, resistance index, and the presence of papillary, at least 4 papillary structures, septations, 6 septations, and nodularity.
Suppose your
scoring system for via ultrasound? Is there any scoring?
Yes, ma'am. RMI scoring.
Okay. Furthermore,
RMI?
Risk of malignancy index, sir.
Very good.
CA 125 ultrasound abdomen. Based on that menopausal status, we can score more than 200 is significant in postmenopausal women.
So there is something called IOTA, that is findings on ultrasound which you can correlate with age and give a score on ultrasound and then connote malignancy or not. High score like RMI. Just because you're a final year, just note that term IOTA. Okay.
Ovarian tumor association, IOTA findings, 10 findings they proposed based on the benign and malignant.
Correct. So nowadays, what is your thought on screening for CA ovary? Screening for carcinoma ovary.
Screening, first.
This patient you said, see this patient, I think in the history you said some history was there, but not very crucial to say it as family history. Imagine this patient had a family history and she's come to you with an adnexal mass. She probably would think of a carcinoma at your side and asking for if said hereditary, doctor, could it be hereditary? Could I had prevented it or not? So how do you counsel her for regarding carcinoma screening ovary?
First, I have to counsel for after childbearing age. I have to counsel for risk-reducing salpingo-oophorectomy, ma'am.
Okay.
Because hereditary cancers are more common.
Do you go straight away for a risk-reducing procedure or do something
Yes,
prior?
CA125 with the transvaginal ultrasound I want to do for every 6 monthly, 3 monthly. Patient is not willing for a risk-reducing salpingo-oophorectomy, then I will do.
But your patient you have not categorized into high risk or average risk. We haven't done anything otherwise.
See, I would screen the patient with CA125 first, ma'am.
CA125?
Yeah. Sanjay, please go ahead, please.
Yeah, only CA125 for screening.
Transvaginal ultrasound also we can do.
How frequently we will be doing that?
6 monthly, sir. CA1, if it is high risk.
6 monthly.
Yes.
Is it annual or 6 monthly? That is, if it is a BRCA positive, I am not saying about it's a proven case of BRCA positive case, then you have to do it annual or every 6 months.
Annually, sir. Proven case of BRCA, it is 6 months, sir.
So, what is the time period when you will do a risk reduction salpingo-oophorectomy?
Sir, there are BRCA1, BRCA2. BRCA1 mostly in 50 to 59 years, sir. BRCA2 more than 60 years. So BRCA1, I want to do risk reducing salpingo by 35 years of age. BRCA2 40 years of age, sir.
Okay. So, what are the steps in risk reduction salpingo? Is it just removing the tubes and ovaries?
Unilateral, bilateral salpingo-oophorectomy with removal of uterus. Also, we can.
Sorry. What is it?
We can.
It is called RRSO, risk reducing salpingo-oophorectomy procedure. So, what would be the steps of that? It is DSO.
You're right. You tell that, Ravina. You are right.
Yes.
Remove both the ovaries and tubes and.
Yes, sir. Tubes.
So, risk reduction surgery will suppose you remove the tubes and ovaries. Suppose the patient has disease elsewhere. So, how will you find out that? Ravina, are you there?
Yes, sir. Yes, sir. I'm listening. Disease elsewhere.
That means, can the patient, suppose you remove the tubes and ovaries, is that 100% protective for the patient?
Sir, it is productive, 80 to 85% productive, sir.
So, whereas the patient can fail after risk reduction surgery.
Yes, sir.
Whereas the patient can fail if you remove the tubes and ovaries. Why it's not 100% protective?
Peritoneum.
Exactly. So, when you do the surgery, you have to sample the peritoneum also. Otherwise, the surgery won't be complete. You have to take a cytological sample and you have to do multiple peritoneal biopsies.
Yes.
Suppose this patient had a family history of, and the BRCA is negative. But what else? What are the other hereditary syndromes associated with ovarian cancer?
What are, sir? What are?
What are the other hereditary syndromes associated with ovarian cancer?
BRCA mutations most common in colon, pancreas.
What is that called? What is that? Can't hear you, Ravina. Can't hear you.
Hereditary and ovarian cancer syndrome.
Yeah, that we talked about. Other syndromes which hereditary cancers which can have CA ovary as a predominant finding.
Lynch syndrome.
Right. So in your risk reduction salpingo oophorectomy, did you remove the uterus?
Yes, sir.
Why should you remove the uterus?
After childbearing is because there is chance of occult meds.
Are you sure you'll remove the uterus? It's oophorectomy. So that goes where it is. BSO, would you do risk reducing salpingo? Would you go for hysterectomy? I'm not sure on that. I don't know. Sanju, what is that? I think this BSO plus that 2 centimeter ovarian pedicle and then multiple biopsies. I'm not sure. I'm not sure.
So it's actually not traditionally mentioned, but it's a case of Lynch that we have to.
Lynch definitely, yeah. Lynch definitely proven. Lynch
But you know, removing the ovaries and keeping the uterus there, usually people want, find a value in that. So gynecologists traditionally remove the uterus also along with RRSO. So it is not traditionally mentioned as mandatory.
Yeah, it is not mandatory, I think, yeah. So in this patient, you have how will you proceed with this patient? How will you proceed? What are the types of, broadly, what are the types of carcinoma ovarian types? Epithelial ovary, what are the broad types?
Serous, mucinous, clear cell carcinoma, endometrioid, undifferentiated.
Okay. What is the most common?
Serous is most common, ma'am.
High grade or low grade is the most common.
Serous is most common, ma'am.
Okay. So what is the current concept change in the origin of ovarian carcinoma?
It is originated fimbrial end, ma'am.
Okay. So what is the recent change in nomenclature regarding the site of when you write the diagnosis in your case sheet?
Mainly serous tubular intraepithelial carcinoma stick. Precursors of this ovary, so they change.
Okay, so if you find stick, then the diagnosis is primary?
Primary
Sorry, okay, so how do you approach this patient? You said there are peritoneal implants. So how do you manage this patient?
Biopsy, ma'am. Omental thickening.
Would you straight away go for a biopsy or?
Staging laparotomy, I can. I would this case in multidisciplinary tumor board approach. After that, for anything possible for staging laparotomy, I can ask the gyneco-oncologist. If it is not possible, then we'll go for omental any biopsy feasible site.
So what are the criteria where you go for primary surgery or primary neoadjuvant chemotherapy? What are the criteria in your patient? Would you qualify them as primary candidate for neoadjuvant chemotherapy?
Neoadjuvant chemotherapy, mainly patient characteristic, poor performance status, any other comorbidities, and the diffuse involvement of the diffuse and deep infiltration into the small bowel, peritoneal carcinomatosis, and omental meds, and any parenchymal involvement, ma'am, and presence of ascites also. We can go for neoadjuvant chemotherapy.
Okay. Presence of ascites is not a contraindication for primary surgery, or that per se doesn't make the patient a candidate for neoadjuvant chemotherapy. But all these all factors you mentioned are right. They are broadly called Leuven criteria.
Leuven and SM criteria.
Yeah, Leuven criteria, just a bit more are there. Unresectable lymph nodal mass or brain mets, and involvement of the small fluids where you cut it and then end up in a short bowel syndrome. More than 1.5 meter loss of colonic loops is going to cause you much. So deep involvement of the mesentery. Those are the points where you go upfront for neoadjuvant chemotherapy. But always, for exam purpose, you tell that you will discuss with your gynec surgeon whether OCR is possible or not. If yes, they will go for primary surgery. If not, I'll go for a biopsy. Okay. Other tumor markers, we said CA125, CA, you will do. Why do you want to do CEA also along with CA125?
Ma'am, if CA 125 by CA ratio is more than 25, it is highly suggestive of ovarian malignancy.
Okay.
And, I want to look for CA.
Okay.
Variety.
Okay. So in your patient,
Ravina, I have 2 questions.
and she's
Your voice is breaking.
Hi, Ravina.
Sir. Sir.
I have 2 questions.
Yes, sir.
One is, what is the stage of this patient as per your MRI report?
Stage of the patient is 3C, sir.
Why do you say 3C?
3C is in stage 3, sir. 3C is involvement of the tumor capsule of the liver and spleen surfaces. So here it is stage 3.
Yeah, so you need to mention the size to say about
More than
3C or
2
not.
centimeters is
Exactly.
3C, sir. Yes.
Now, suppose your gynec surgeon is saying that this case is operable straight away. Will you do a biopsy?
No, sir.
You won't do a biopsy.
Yes, sir.
If you don't do a biopsy, what else should you do before going in for a surgery? What is missing? I think Tejaswida Singh, she has to mute her phone. Mute her. Yeah. Tejaswida Singh. So, before going in, suppose the surgeon is telling that I can operate this. What else will you suggest as a medical oncologist before allowing the surgeons to go in?
Biopsies, random peritoneal biopsies, I can ask the surgeon, sir.
That is during surgery. What I am asking is before going in for surgery, what else, if you are not doing a biopsy, what else should you do in this case and why? So your CA125 is 300 something, right?
Yes, sir. Yes, sir.
So can CA125 be elevated in Krukenberg?
It can be, sir.
Okay. Now what will you do? It's a bilateral tumor.
Ascitic fluid tapping, the cytology, and endoscopy. In this
Exactly. So you have to do the upper GI scopy and colonoscopy before
Good
going in.
Yes, sir.
Patients at a stage, then we have curative available local ablation, surgical resection, liver transplantation. Median survival over 5 years, if not.
Go ahead. Yeah. Divina?
Sir.
Yeah, so go ahead. So you will do upper GI scopy and colonoscopy.
Yes, sir.
Completion before
Yes,
going in. Because presence of ascites, presence of bilateral tumor, raised CA125 will not guarantee a diagnosis of primary epithelial ovarian cancer. So if you have bilateral tumor, it is mandatory if you go in for a primary cytoreduction. Okay.
Okay.
Yeah. So, you told about. Can you mention about the steps of staging laparotomy?
Steps of staging laparotomy: midline incision from jiffy sternum to pubis, and ascitic and peritoneal fluid lavage, tumor resection and frozen section evaluation to look for opposite contralateral ovary, and to remove this fallopian this tube implants and uterus, and omentectomy if omentum is grossly involved, random peritoneal biopsy from paracolic gutters, cul-de-sac, and lymph node dissection, inspection of the all systemic inspection of all surfaces, like in clockwise manner from cecum to ascending colon, right hemidiaphragm, liver, transverse colon, left hemidiaphragm, descending colon to cecum in clockwise direction.
Now tell me, what is a difference in these steps if the patient has suppose early ovarian cancer versus suppose the patient has advanced ovarian cancer?
Early lymph node dissection, sir.
Yeah. So what is the difference?
Lymph node lion trial proposed by Philip Harter suggested that if there is any grossly involved nodes, we have to take that nodes. Otherwise, there is no need for para-aortic and pelvic lymph node dissection. And then post-op complications are more in the trial, with the median overall survival months is like only same 64 months and 65 months.
Okay. So in an advanced ovarian cancer, you won't do lymph node dissection.
Yes, sir. I want to remove the grossly involved. I don't want to do lymph node dissection. Hello?
Yeah.
Yes.
Yeah. So lymph node dissection for advanced ovarian cancer, it may not be warranted. Early stage, you can. Why should you do lymph node sampling or dissection in early stage ovarian cancer?
Sir, in the early stage also there is upstaging of lymph node dissection is possible, sir. So early stage also there is a chance of 25% of upstaging. So that's why.
Ravina, what percentage of patients are going to be upstaged if you do a systematic node dissection?
Stage 1, 25%, ma'am.
Around it is 30%. It's
Yes,
hard. It's very difficult to remember stage. So we keep it 30%.
30%.
But line trial was done for interval debulking. It was not for primary surgery. Okay, so just the scenario was different. Would you go for a system? You said if the omentum is involved, you will do an omentectomy. The surgeon will do an omentectomy. Is it mandatory that omentectomy is a part of the procedure, or if it is only enlarged? How is that?
Only enlarged grossly involved means omentectomy. Otherwise, infracolic omentectomy we can.
It is almost a mandatory procedure. So how far you debulk depends. Maybe some patients would have omentum only just below the infracolic area. So in them, that is okay. But supracolic omentectomy is a part of the procedure. You cannot omit on that.
Yes.
Okay. So intra of the patient, your patient has actually gone for OGD and lower GI-scopy and gone for a biopsy. How do you debate between neoadjuvant chemotherapy? Imagine if this was a borderline case. The surgeon can operate or you can give chemo. It's a borderline case. So how do you debate between neoadjuvant chemotherapy and primary debulking? What is your current understanding on how do you choose a patient for any one modality?
Borderline, I don't want to give, ma'am. After surgery, we can observation.
No. I said not a borderline histology. I said it is a via media case, whether you can go this way or that way for neoadjuvant or primary surgery.
NSCT versus PDS. There are 3 trials comparing NSCT versus primary surgery based on EORTC trial, Chorus and Scorpion trial. MRC Chorus is a non-inferiority trial suggesting that primary chemo before surgery is an acceptable standard of care. It is a median survival months was 24 and 26. 24 months in chemo arm and 22 months in primary surgery arm. Whereas in EORTC suggested by Vergot et al., there is both PDS and NSCT is having similar OS and PFS benefit. And morbidity is lower in NSCT group. In this EORCT trial, ma'am. In Scorpion trial, Fagotti, suggested by Anna Fagotti, there is no, that trial is not good and it didn't reach the maximum level. OS and PFS benefits also same, and it's not having any good results. So based on that MRC Chorus, I can suggest NSCT is better in stage 3 to 4 epithelial ovarian.
Okay, fine. Because your morbidity is going to be less, the patient is going to tolerate your chemo, and then the hospital stay, all the post-op complications, and the patient will be adequately nutritionally better when the patient goes for a planned surgery after your chemo? How many what chemo regimens are there for your first line treatment?
For first
CMS
line,
has taken biopsy, and what is this patient's biopsy report? Sorry, I forgot to ask you.
omental biopsy features suggestive of high-grade serous carcinoma with IHC ER positive, PR negative, P53 aberrant, WT1 positive, NABCA negative. So high-grade ovarian carcinoma.
Yeah, since you have said P53, what is P53 signature in C ovary?
P53 is indicates only prognosis, ma'am. Bad, poor prognosis to chemotherapy. Recurrence chances are high.
Okay, go on. We'll do. So how will you go about chemo with this patient? High grade serous?
High-grade advanced stage. I want to give first initially 3 cycles of chemo with paclitaxel and carboplatin, ma'am.
How do you write a prescription for this patient?
Injection ondansetron 8 mg plus injection dexamethasone 8 mg in 100 ml NS over 15 minutes, followed by injection Evil 25 milligrams IV start, injection ranitidine 50 milligrams IV start, tablet paracetamol 500 milligrams per oral start, injection paclitaxel 175 milligrams per meter square in 500 ml NS glass cordon bottle set over 3 hours, injection carboplatin of AUC 6 in 5% dextrose over 1 hour, followed by saline flush 100 ml.
What is the ideal pre-medication for paclitaxel?
Ideal pre-medication ranitidine Evil, ma'am. Paracetamol.
Only that? Steroid. What is the
Steroid
dose of
injection dexamethasone also, ma'am. It prevents
What is the
hypertension.
dose? What is the dose when you give it?
In our protocol, we will give 8 mg, ma'am.
Just before chemo? Is it?
Before chemo, we will give 8 mg only, ma'am.
Before that, you don't give anything? Sharpness says you should give 20 milligram. That is the standard pre-medication. 20 milligram. You can give it either OP as an OP basis or IV. 6 hours prior and 12 hours prior to your time of starting Pacli. Imagine the patient has undergone, they forgot to take it, Pacli, the Dexona pre-med. So would you, the next day you get a call from the casualty saying, madam, this patient has forgotten to take the pre-med. So can I postpone it? Or can I give it the same day?
Same day we can give, ma'am.
With what precautions?
Precautions. Dexamethasone will we can ranitidine.
Half an hour prior, you can give again, not again because they have not taken it previously. You can give 20 milligram IV half an hour prior to your chemo, and then you can actually infuse the chemo, not without steroids. Okay, why do you want to pre-medicate her with these things? Why should you be careful?
Paclitaxel will cause more hypersensitivity reactions, ma'am. Okay. So that's why we want to pre-medicate.
Why is it that due? Why is it that due to?
Because paclitaxel is a low solubility molecule. It's composed of chemophore-L and ethanol. So it is the more caused anaphylaxis reactions.
Okay. Imagine the patient is on paclitaxel, 3-hour infusion, then got carboplatin. While on carboplatin, the patient is having some sort of reactions. So would you attribute it to paclitaxel or carboplatin?
Paclitaxel only.
Paclitaxel. Carboplatin will not give reactions?
It will give, ma'am, but only 10%.
Yeah. What is the difference between the paclitaxel hypersensitivity and carboplatin?
Ma'am, voice is... Hello?
What is the difference between paclitaxel hypersensitivity and carboplatin hypersensitivity?
Paclitaxel hypersensitivity is more, ma'am, 80 to 90%. Carboplatin is only 10%. So yeah, carboplatin less likely to cause hypersensitivity reactions.
Yeah.
When does
the basic difference? See, the paclitaxel, whenever you infuse, there is always a chance of reaction. If we be it in the first cycle or the sixth cycle or in the relapse setting, wherever you give, each cycle carries a risk. But carboplatin, the mechanism is that you have pent up accumulating antibodies in your body with each dose of carboplatin. So that carboplatin side effects can also occur, but usually seen at the end of your planned 6 cycles, maybe in the 5th or 6th cycles. So that is a basic difference. One is the property of the drug which the patient is just getting, paclitaxel, or it is due to the repeated infusions of carboplatin. Okay.
Okay.
So that is a basic difference. So what is you said 175 per meter square and AEC 6 every 3 weekly. How many cycles of neogen chemotherapy would you prefer?
3 cycles, ma'am. After that, I'll send the patient for interval debulking.
Okay.
So, Ravina,
would you add bevacizumab to your primary regimen?
Ma'am, I can add stage 4 disease young patients. I'll give option of bevacizumab, but if we give bevacizumab upfront, we have to continue maintenance also. If you continue maintenance only, according to GOG 218 trial suggesting that there is increase in PFS benefit only by giving maintenance bevacizumab.
Okay. So Dr. Sanju had a question for you.
So carboplatin dose, how will you cap carboplatin dose?
Sir, carboplatin according
to 6, what will be the maximum dose what you can give?
5 to 6, sir, in ovary.
Yeah, you see 6. Suppose you calculate and you find that carboplatin dose is coming to 900. Will you give 900?
No, sir. I can cap it 450, sir. 450 milligrams.
So that is the maximum dose you give for carboplatin?
650. 650, you can.
No. So, so that you need to check because
for each AUC, you have upper limit. So
exactly.
AUC 6 is 900, 5 is 750. How do you calculate the formula? Like, how do you calculate the AUC? What is your formula for calculating the dose?
Calvert formula, total dose milligrams is equal to AUC into GFR plus 25.
What is that 25 for? What is that 25?
20 for this dosage.
We'll calculate the GFR. We'll additionally give an allowance of 25. Why is it that for? Have you thought about that?
Yes.
No. It is for the tissue binding. Just go and read the basics. Because for the exam, for the DM practical exam, all these basic questions are going to come up for you. Or not hi-fi questions, and the trial which was published in the last week Lancet, nobody is going to ask you. It's all very, very basic questions. So 25 is for the tissue albumin binding part. Okay.
So suppose Ravina, this patient had pre-existing neuropathy. How will you proceed? Patient is a diabetic for 10 years. Patient has grade 2 neuropathy. Will you offer paclitaxel or will you change your plan?
I'll change pre-exist grade 2. I'll change, sir.
So what will you offer? What data do we have?
Docetaxel we can give, sir.
Okay. Anything else? Suppose a patient is adamant that I don't want any alopecia.
Liposomal doxorubicin.
Exactly. So very good. We can offer both. Docetaxel also will have neuropathy, but that is a safe alternative. We have data for that.
Yes.
The patient is coming and asking you whether I can give nab-paclitaxel instead of paclitaxel because there is neuropathy on paclitaxel. Can I opt for nab-paclitaxel? What would be your comment?
Frankly, I won't give nab-paclitaxel. I can suggest liposomal doxorubicin.
So will nab-paclitaxel counter your peripheral neuropathy part?
Yes.
Will nab-paclitaxel cause more neuropathy or less neuropathy?
Less neuropathy, sir.
Is it? What is the dose of nab-paclitaxel?
125, sir.
125
milligrams per meter square.
That is every 3 weeks?
Yes, sir, every 3 weeks.
Oh, no. That is one advantage of actually delivering higher doses of paclitaxel. Is one advantage of using the nanosomal paclitaxel. Okay, it's actually 250.
250 to 260, yeah.
So, Dr. Lakshmi was asking about use of bevacizumab. Where will you consider bevacizumab?
Bevacizumab in
That is in refractory setting. What I'm asking is in a primary setting, newly diagnosed case, where will you use bevacizumab? Use?
Yes, sir. Stage 4 engage advanced. I can suggest bevacizumab upfront.
Yeah, age is a criteria. Suppose a young patient is coming with stage 3C. Will you use? What is the criteria?
Age is not a criteria, sir, but young patients tolerability is good.
Okay.
Imagine this patient was an elderly 75-year-old, ECOG 2 to 3. What chemo modifications could you suggest?
Elderly is I can suggest weekly carbo and paclitaxel, ma'am. Carboplatin AUC2, paclitaxel 60 milligrams per meter square.
Is there any 3 weekly modifications?
3 weekly also is there, ma'am. Japanese style and all they suggested 3 weekly also.
So what is the paclitaxel dose in that regimen?
80 milligrams per meter square.
80 milligram is actually a weekly regimen, but 3 weekly regimens you can give instead of 175, you can give 135. 5 to 7 trial. Okay. What is your idea on dose dense schema for primary NICT dose dense schema?
They have tried, ma'am, dose dense, but more toxicity is there, ma'am. That's why 3 weekly is better than dose dense.
Okay. Okay. So moving on with the case, after neoadjuvant, you've completed your neoadjuvant, then you go for send the patient for surgical evaluation. If operable, they will go for surgery, and you will go for staging lab. The surgeon will go for staging lab. And you will like the patient after suture removal with the HP. Go on.
Yeah.
You got that?
No.
Yeah, I'm there. Yeah, you have got the patient after your surgery.
Yes, ma'am.
With the HPR, and the sutures are all removed. What is the ideal time to start adjuvant chemotherapy?
After 30 days, ma'am.
Okay. Now it is said within 6 weeks. Okay, not if there is not a cause, don't delay it more than 6 weeks. So in the pathology, what all will you concentrate? Pathology report, HPR.
Type of the tumor first.
Yeah.
Tumor size. Any involvement, peritoneal, any implants.
Yeah, sure.
Lymph node involvement.
Yeah.
Any whether it is a R0 resection or not.
What is the resection terminologies for carcinoma ovary?
Optimal site, complete site reduction, optimal site reduction, and suboptimal site reduction, ma'am.
Okay. So define complete site reduction.
Complete site
between OCR and CCR.
Complete site reduction means no visible disease. Optimal site reduction is defined by GOG is less than or equal to 1 centimeter. Suboptimal is more than or equal to 1 centimeter.
Okay, if the patient had optimal site reduction, would you advise her intraperitoneal?
Ma'am, interval debulking, there is no IP chemotherapy only upfront. I can offer for HIPEC.
Yeah, HIPEC. So which group of patients would you advise HIPEC?
HIPEC, stage 3, ma'am, HIPEC, hyperthermic intraperitoneal chemotherapy, I can offer the patient. By doing this interval debulking plus HIPEC, I can tell the patient that there is a 3 years recurrence-free survival in the HIPEC group, 17%, 8% in CRS group, and 3 years median overall survival benefit also more with HIPEC, that is 62%.
So would you weigh the toxicity more or the benefit more?
Both, ma'am, equally IPEC, long ICU stays are there, ma'am, in HIPEC.
Okay. So what are the agents which are commonly used for HIPEC? Chemo agents.
Cisplatin, ma'am, 100
Cisplatin?
milligrams per meter square.
Yeah.
Previously, they used olden days. Previously, they used mitomycin C, but it is no, cisplatin is commonly used.
This one which is commonly used. What are the criteria for you to select a chemo agent as a good HIPEC agent or intraperitoneal agent?
Criteria, cisplatin is best in suggested in NCCN guidelines and Vandal et al. Trial also they are telling, ma'am. 3 randomized control trial also they told, but cisplatin is the best option by Vandal et al.
No, I did not ask you that. What are the properties of a chemo medicine to get it qualified as a chemo, as an intraperitoneal agent?
Intraperitoneal, because they should have a low solubility, high concentration to cytotoxic drugs.
Yeah.
So cisplatin, they're having more benefit in peritoneum.
So, Ravina,
Okay.
where will you use primary intraperitoneal chemotherapy? What is your take on?
Sir, primary IP therapy, I'll use primary upfront after primary cytoreduction. After that, I will offer for IP therapy, sir, intraperitoneal. Can
you give me a prescription of IP chemotherapy?
Yes, sir. IP chemotherapy by GOG 172 suggested by Deborah Armstrong regimen, sir. First day 1, day 2, day 8. Day 1 IV paclitaxel 135 milligrams per meter square over 24 hours infusion, sir. Day 2 IP cisplatin, that is 100 milligrams per meter square. Day 8 IP paclitaxel, that is 80 milligrams per meter square.
So suppose this patient is 58 and had family history, and the patient is found to have massive ascites. A germline test was done and BRCA1 mutation is positive. How will you plan?
Sir, after completion of surgery and after completion of 3 cycles of chemotherapy, if a patient is BRCA1, BRCA2 positive, high grade serous, I would like to do BRCA testing. If it is positive, then I would give PARP in maintenance, sir. That is based on solo 1 trial, olaparib, 300 milligrams BD for 2 years, sir.
Okay.
When will you start? When will you start PARP inhibitors?
After completion of surgery, after completion of chemotherapy, I want to start PARP inhibitors.
Do you do any evaluation in between?
I want to do CA 125.
You should prove that the patient is not progressing after platinum.
Yes.
Only then will there be a benefit, and then if so, you can prescribe.
So what are the common side effects of PARP inhibitors?
Sir, mainly anemia, sir, thrombocytopenia, fatigue, persistent cytopenia, and there is a risk of secondary malignancies.
Like?
AML, MDS, sir, 1 to 2%.
Okay. Now say this patient has completed 3 cycles of chemo, underwent interval cytoreduction, and after that received 3 more cycles of chemo. Then this patient is put on follow-up. How will you follow up this patient?
Follow-up CA 125, sir. First CA 125, 3 monthly for 2 years. And after that 6 monthly for another 5 years, sir.
So after 9 months,
yes,
your CA 125 is, the baseline after completing treatment was suppose 4. And now after 9 months, your CA 125 is now 30. What will you do at that point?
Sir, without patient is asymptomatic, I would do follow-up only, sir. Patient symptomatic, I want to do imaging, sir. Based on
Even if the patient is not symptomatic, Dr. Sanjay said 9 months, no?
Yes.
9 months. So won't you evaluate? Before that, once you put the patient on follow-up and you give them regular prescriptions to do CA-125, come back on this date and all, what extra advice will you give to the patient? And before that, nowadays, even though we say PARP inhibitors, many of us are hard short of putting it because of financial issues. So before putting the patient follow-up, would you go back to the pathology, and pathology means interval cytoreduction pathology, and on a case-to-case basis, how do you modify your follow-up plan?
Based on the section status, ma'am.
Yeah, the section status and one more. The section status and one more in the pathology. What is that? That is complete. CRO score, chemo response score. So
Yes.
that goes in very well in hand with the follow-up and the recurrence pattern. So if you see a report which is CRS3, you should be very happy. These patients are not going to relapse that fast. But 1, 2, beware. You alert them. So when you put a patient in follow-up, see this pattern and alert the patient. Apart from this set dates, even if the patient is symptomatic, bring the patient. Okay, that is a standalone advice for all ovary patients. So at 9 months, go back to Dr. Sanju's question. 9 months, would you evaluate, or how do you take her?
9 months, I want to evaluate with imaging, ma'am.
You just put it 12 months for discussion part. If the patient has a CA-125 rise, asymptomatic patient at 12 months, how do you go about it? Again, CT? Why? If so, why do you want to do a CT?
If more than 12 months, if CA-125 rise is there, then secondary cytoreduction we can think.
If the patient satisfies which all criteria?
Ma'am, in secondary cytoreduction, good performance status, there is no ascites, no carcinomatosis, complete surgery after primary surgery, there is no residual disease. So based on this desktop 3 trial in secondary cytoreduction criteria,
okay,
that patients qualify for it.
Okay, imagine a situation, one such patient has gone in for secondary cytoreduction with good resection status. And what is platinum resistant disease in ovary? Platinum resistant?
Platinum progression on treatment less than or equal to 6 months after the last platinum dose is platinum resistant.
Okay, so this patient has gone in for 12 months evaluation, asymptomatic, had gone secondary cytoreduction, and now comes to you back for opinion on chemo. How do you?
Chemo, I can try with bevacizumab, ma'am. With the bevacizumab, resistant cases, any single agent that combined with bevacizumab, I can try. Second line agents.
Okay. Okay. So the patient is asking you whether they can be on maintenance, second line maintenance.
Second line maintenance also we can give, ma'am. Olaparib, there is a role solo 2 trial, and niraparib also we can give based on phase 3 NOVA study. Second line maintenance we can.
Okay.
Tell me what are the regimens you will be using for in platinum sensitive relapses?
Gemcitabine, sir, platinum sensitive gemcitabine, carboplatin plus bevacizumab.
So what is the dose of gemcitabine? What is the dose of carboplatin in this setting?
Gemcitabine 1000 milligrams per meter square, sir. Carboplatin AUC 5 to 6, sir.
No. Gemcitabine plus carboplatin AUC is 4.
4. What happens if there is a comparison where you give AUC 4 and 5 with gem? So what is extra risk in giving AUC 5 with gem?
Nephrotoxicity, ma'am, gemcitabine, and carboplatin also nephrotoxicity, and platelet sparing.
Yeah, thrombocytopenia, more amount of thrombocytopenia. So gem carbo in ovary, it is AUC 4. Okay. What side effects of bevacizumab? Just last question. What are the side effects of bevacizumab? Common side effects.
Common side hypertension,
Yeah.
bowel perforation, poor wound healing, proteinuria,
Yeah. 2 more. Thrombotic events, both arterial and venous. Then you don't re-challenge.
deep vein thrombosis,
And arterial also you can have. Arterial also. And fistulas.
fistulas.
Fistulas. I think it is 8:30. So do you have time or you need to close, Dr. Arun?
I think 1 hour is good, ma'am. We've completed 1 hour. So, ma'am, final comments, like how did the candidate perform from both you and Dr. Sanju? Your opinion? Anything?
Ravina has done, she has done very well. So I think excellent, very good.
Yeah, same opinion here too. She has almost answered the questions. Just a polishing is needed. And always when you present the case, go by the DAS clinical book, okay? In the steps, whatever they have mentioned, okay, in the mention. So about whatever headings they have put for the examination, if you follow that, it gives a good impression before the examiners, okay? And always in the what these general examination you said, no, I said you to avoid all those generally built and moderately nurtured. We don't need that in the DM level. And BSA, body surface area, you should calculate. Because we are going to, we are chemo people, we are going to write prescriptions. So BSA is a standalone criteria for among the vital signs for DM medical oncology. Okay. That's it. All the best. All the best for our exam.
Thank you, sir. Thank you, Arun sir, Lakshmi ma'am, and Sanju sir for creating this platform. Thank you very much.
Okay, once again, yeah, thank you to both our examiners who did a wonderful, wonderful job. And thank you, Dr. Ravina, for your time and effort. So thanks for everyone who's joined in also. And on the behalf of Ampok, thank you once again. We'll see you again next month. Bye-bye and good night.
Good night.
Okay, good night. Bye.